Francesco hem bizim misafirimiz hem de çok önemli bir konuda konuşma yapacak. Düşük riskli hasta.
Tricuspid, but only 2 or 3% get it. So let's say the operator needs to be acquainted with the valve, and I suggest you use the valve that you're acquainted with the most. Ali Ibrahim, I agree. Yes, you have to use the valve that you're most acquainted with. That's for all general procedures. That's an important issue. But if this is not evidence-based, and regard the constraining part of bicuspid valve, so it remains there. If you assume that a restrictive part remains and it's not circular, and I would say Evolut R is more appropriate. Preparation is essential, yes, and non-circular structure. I mean, we start 13-14 millimeters above the annual, and that's where the annual level is, and the circular area remains above. But this is my personal point of view. It's not evidence-based, and maybe you use both valves. I don't know if you're experienced in that, or Francesco, if he wants to say, are you using both valves?
Yeah, yes, we do use both valves, but I agree with the previous comment that you must use the valve that you're more familiar with, because I think there are nuances in bicuspid that goes beyond the general procedure. So, for example, in a horizontal aorta, all let's say what we said about the predictability of the landing zone. And you have to adjust your technique based on the valve you are using, because, for example, for a balloon expandable, even in bicuspid, I do not predilate that much, but I think that in self-expandable is very important. And I agree also with the comment about using balloon sizing, because yes, we do a lot of theoretical measurements, not theoretical, practical measurements in the CT scan, and theoretical assumption about the flaring and this and that. But then sometimes it's just gut feeling what you think will happen with the raphe. For example, when it's very calcific, sometimes the raphe is not so resistant. Sometimes absolutely you cannot really push the raphe away. So I think in many instances, balloon sizing may help deciding.
I think Mustafa has a question. Cem, I would like to talk about a case which was simply a 68-year-old patient. It was an annular valve and it did not open. There was predilatation, despite predilatation and post-dilatation, and there was stroke throughout the procedure. And we simply and it was not still opening. And we did balloon, and then unfortunately the patient passed away because of the intracranial bleeding. So it is case-based, but in very high intensity calcific cases, supraannular valve might be simply prominent, but very strictly calcified cases. So actually, even though there was very thorough predilatation and post-dilatation, unfortunately I don't have the visuals with me, but maybe in another platform. Thank you so much. So I would like to now move on, because we are completely at the end of our time, but we have our distinguished guest, Francesco, and he was going to be talking about a very significant question, TAVI in low-risk patients. Francesco, the floor is yours. Thank you.
Thank you very much. And thank you for the invitation. This was really interesting for me. Outstanding presentation, really, thus far. I mean, we covered together all the most important issue of TAVI, and now we move to a more clinical and controversial issue, which is TAVI in low-risk patients. We know. My slides are not moving. Okay, yeah, we know that TAVI has in the background really a huge number of trials, is almost unprecedented, going through all the risk categories of the patients. I'm not going through this. Just to say that with all this incredible background, we ended up having the current guidelines with a class 1 indication in the ESC guidelines for prohibitive and increased surgical risk. And in the American guidelines, intermediate risk is 2A, but just because it was published, the guidelines just before the presentation of the second big intermediate risk trial. But we know also that these guidelines are a little bit outdated, because shortly after we had the presentation of these two pivotal trials, the partner 3, low risk, demonstrating reduced rates of a composite primary endpoint, death, stroke, and rehospitalization with the TAVI in comparison with surgery. And we also had, okay, the core valve low risk trial demonstrating non-inferiority of the core valve in comparison to surgery up to 2 years in the primary endpoint composite of death or disabling stroke. So, and we know that at the moment we have approval for low risk both by the FDA and in the European agency. So we also had previous trials, smaller scale trial, the NOTION trial, demonstrating in the similar outcomes between TAVI and surgical aortic valve replacement. And we also had this US ID trial, 200 low-risk patients, single arm, demonstrating, you can see here, excellent clinical outcomes at 30 days. So end of the game. This is what we can, let's say, putting together available evidence nowadays. We can say that there are factors favoring certainly TAVI, which are less bleeding, less renal complication, less atrial fibrillation, shorter hospitalization. On the side of aortic, surgical aortic replacement, we have certainly less paravalvular leak, lower pacemaker rate, and lower incidence of vascular complications. Apparently, taken all together, we can say that this prophecy of Professor Vahanian came true. I mean, in 2020, perhaps TAVI is considered the default treatment of patients with aortic stenosis, but it's really like that. I mean, first of all, take a look at what's going on in Italy nowadays. This is our perspective. Those are Italian data. Certainly, we have an increase, but please note 2019, 8,000 implants. According to current indications, so intermediate risk, we should have at least twice the number of implants. And with the expansion to low risk, we should have 3 times as many implants as we had last year. So, I mean, certainly there are issues also logistic that we will have to take into account for the future. This is what happened in Bologna. Our institution, in blue you have surgical, and then in red you have TAVI. Those are all the biological aortic valve replacement. And surely you can see that over the years we had a kind of inversion of the curve favoring TAVI overall. And you can see that at the beginning there was a positive effect also on the number of surgical procedures that now are decreasing continuously. So this is, I mean, the background. But what is, we need to think a little bit about what is low risk. Is it low risk? What is defined by the score? If we look at the score, we have less than 4% in STS and Euroscore 2, or less than 10% in Euroscore 1. But please take attention to those 3 patients. Those 3 patients, they fell into the same ST score category. So the 3 of them, all of them are low risk classified according to STS, but they are completely different. Number 1, 60 years old patient, no comorbidity. Number 2, 90 years old patient with a little bit frail, but still low risk. because no other major risk factors. Number 3, 80-year-old lady with some comorbidity and a special prior radiotherapy and severe calcification of the aorta. The true classification of this patient is not low risk, is low risk for the first, is intermediate for the second, and is high risk for the third. I'm not saying anything special. I'm just saying that low risk cannot be defined only by surgical score. And also, this is, again, sorry to quote my experience, but this is our experience, just to say, and the years were 2008, 2017, so much before the approval of low risk and the low risk trials. And you can see that if we just take a look at the surgical score, we were treating around 40% of the patients with a low risk score. And we also know that those scores do not predict in hospital outcome as well as they do in surgery. So this is an important slide, I think, to make an important point. I mean, the major difference in going between the surgical trials and the surgical arms and the TAVI arms of trials, going from extreme high risk, intermediate risk, and low risk, you can say is age. You can see that age in surgery comes together with the surgical risk. While in TAVI, especially in the first trials, in the early period of TAVI, low risk, they were all old patients. And with the last two trials, the Partner 3 and the Corval low risk, we have just partially filled this gap in age, this age gap between surgery and TAVI. So there are indeed some issues with the evidence that we have thus far in low risk. This is very much highlighted by surgeons, and I think it's fair to acknowledge some of these limitations, namely sample size and number of events, trial design and generalizability of the results, and long-term follow-up. I will not talk much about sample size, simply just to say that there were much less patients in the low-risk trials in comparison with the previous trials. Going into trial design, we know that Partner 3 had a very selective enrollment. The primary endpoint including rehospitalization. The follow-up was at the beginning only 1 year, and we still had a threefold higher rate of concomitant procedure with surgery. And in the core valve low risk trials, we know that there were wide non-inferiority margins, and the trial had a Bayesian design, and only a small percentage of the subjects enrolled completed the 2 years follow-up versus, for example, more than half in the SURTAVI trial. So this is certainly a limitation in evidence. I mean, the evidence is not so strong, but also going deeper in the trial, please note the difference between low-risk trials and the low-risk registry STS American. Number one, I just want to point out two elements. Age again, 65 years old, low-risk patients in the American registry versus 73, 74 in the TAVI trial, and 50% bicuspid aortic valve in the low-risk registry American again versus a contraindication, I mean, not contraindication, but not enrolled, contraindication for enrollment in the trial. So we miss some evidence. And then long-term follow-up, we know that long-term follow-up is important for all the patients, and we know that we have reassuring data for TAVI. I will go back to this, but I think that the story is completely different when we talk about 85, 90 years old patients in which, I mean, life expectancy is 5 years. So we don't need to wait to have 20 years follow-up of TAVI to say that TAVI is good enough and maybe is the preferred, actually is the preferred therapy for these patients. But if we go to very younger patients, very long life expectancy, then we need to wait more, I mean, solid results over long term. And we know how much the surgery highlighted this crossing of the curves after 2 years in the partner 2 intermediate risk, showing that the number of events after 2 years in terms of death and stroke was higher in TAVI in comparison with surgery. We have, however, to acknowledge that this included transapical access that we know that carries worse results, and there was a detrimental impact of moderate severe paravalvular leak, and here we were dealing with the Sapien XT valve, so a kind of previous generation valve. We also, on the side of reassuring data, we have now the data of the 2 years data of the partner T trials confirming the superiority overall of surgery, of TAVI over surgery in this patient population. So other reassuring data, these were, we know how much in talking about the surgery, we know how much sparse are the data about surgical valve duration, because we know that the prostheses are different. We know that the definition used are different. So going deep into the durability data that we have for surgical valve, we cannot say that much. I mean, the indirect comparison does not add that much, but direct comparison was made using the current definition of a structural valve deterioration and bioprosthetic valve failure according to the definition, the consensus definition that now should be adopted. And we know that using consistent definition, the incidence of structural deterioration up to 6 years was actually higher in surgical prosthesis in comparison with TAVI. So certainly we do have reassuring data, but I think we should wait a little bit longer. We also know that with the newest generation valves, the results are sharply improving. These are the results of the first 100 cases did in Europe performed in Europe with the Sapien Ultra, and you can see here that the incidence of moderate severe valvular leak in those first 100 cases, and I can tell you that these stayed pretty much the same even in the largest series afterwards. And you can see that also pacemaker rates with this new valve, my special new technique of implantation, has sharply decreased in comparison with the past. And the same path, we can say something very similar for the core valve, improving sharply over the years in terms of incidence of moderate paravalvular leak, and also reduction of the incidence of pacemaker. And we know that the Evolut Pro also made further progress in terms of reduction of paravalvular regurgitation, together with, of course, expertise of the operator. And this is a bicuspid valve. I will not touch upon bicuspid, but we know how much, we heard in the previous presentation how much we can do in terms of planning and procedural details to optimize the results. And actually the results of the published registry are very good. And indeed, we have now also the market approval, CE market approval for the core valve for bicuspid. And we have no mention for the Sapien, meaning that is not contraindicated, which is important, having no mention in comparison with having a contraindication. Then we have implemented over the years a lot of detailed optimization of the procedure, simplification. The first two listed here, I think, really changed the incidence of vascular complication, ego-guided access, and second access using radial. Then we have, streamlining the procedure using maybe pacing through the wire in the left ventricle. Although this, is not something that will improve the outcomes, and we may have protocols of early mobilization, early discharge, and we know that these are able, especially in elderly patients, to improve the results. So I think I made the point that TAVI in low risk is not a problem in the early, in the elderly, but when we consider young patients, so this is a different story, and in young patients we have new issues. which are those new issues is coronary access becomes more important, very long-term durability, I already mentioned this, and the feasibility of a redo TAVI in TAVI in those patients. So very briefly, coronary access, we know that especially in patients with coronary disease may be important, especially in young patients, because we may need to reaccess the coronary, and we know that the valves are not the same. There is a different height of the frames, different height of the skirt, different height of the valve, intraannular, supraannular. We have different open cell, closed cell, so different design of the valve. So the factors to consider is intraannular, supraannular, open, closed cell, the skirt commissural height, the valve to aorta distance. I will not deep dive into that, but of course we know that the difficult may be different based on different valves and different anatomy of the aortic root. And then durability, I already mentioned this, is completely different. I mean, if we think about a patient 60 years old, we could predict, is not, I mean, this is now, it's only speculation. He may need a redo intervention, maybe in 10 years, so may do 2 re-interventions. So we have to think upfront about that when we think about young patients. And when I say think upfront, I of course, we need to think about durability. Different valves may have different durability. This we will know when we will have more data. And the moment we can only speculate, we can speculate if supraannular may degenerate less in elliptic anatomy or not. We don't know at the moment. This is something that we will learn. But what we know today is the difference that we may have in terms of coronary, because in coronary we need to consider that the leaflets of the TAVI valve will be a kind of cover stent when we do a TAVI in TAVI procedure. I invite you to read this is a very interesting paper of Giuseppe Tarantini assessing what may happen in terms of the so-called risk plane in comparison with the height of the coronary ostia, the height of the valve in comparison with the plane of the coronary, and the valve to aortic wall distance. So those are all to take into account, and every kind of valve, for every valve you need to do some consideration. So I think for the future, and especially if we will think about treating very young patients, we will need to think about that. We will need to think about the future. So my conclusion, TAVI represents the best therapeutic option for elderly patients with aortic stenosis, irrespective of surgical risk category, including low-risk patients, in my opinion. But again, elderly patients. For younger and low-risk patients, I think it is already a reasonable alternative, but stronger evidence and very long follow-up are needed before extending to cure the indication to these patients. So I think it's still a matter of a heart team decision, important in patient. And TAVI in low-risk patients should be performed by expert operators who are able to achieve excellent procedural results. And I think that following what my colleagues said in the previous presentation, this is what we can do, adopting all the measures that we already know today can really optimize our procedures. Thanks.
Dr. Francesco Saia'ya çok teşekkür ediyorum.
Dr. Francesco Saia, thank you so much.
Mükemmel bir toplantı, mükemmel bir...
It was indeed a perfect presentation. It has been nothing but a perfect webinar. Efendim siz galiba kanalınızı mı değiştirdiniz?
Hemen bakıyorum.
Well, it was indeed an excellent presentation. Well, actually, the perspective has been expanded. When we say low risk, well, we are thinking of young patients in the first case. But okay, you know, the earlier studies indicate that low risk, but actually elderly patients. So, you know, when it is indeed young patients, it is becoming more complicated and requiring more optimization. Do we have any contributions from the panelists? Well, if you just allow me, I would like to say a number of things. So, Dr. Francesco, first of all, thank you so much. So vis-a-vis the low-risk group, there are some questions in our mind because when we look at partner 3, 25% are patients younger than 70, 75, which is going to pose a durability problem. And the second thing is, the surgeons, for their own operations, the surgeons are modulating a risk score, and we're using that for our TAVI procedures. So, you know, for the upcoming mortality, either 30-day mortality or, you know, for the future mortality, there is an important predictor: transfemoral entrance, transapical, coronary ostium, and the other factors have to be taken into consideration. And they're not involved in that STC score, right? Therefore, what we call low risk, there are so many factors impacting TAVI, and actually those risk factors are not involved in the risk module. That's a handicap. That's a disadvantage. And only 25% of those are young patients. And for the durability, that's not going to simply help us in the upcoming times in that low risk group. In addition to that, so maybe from 24F, you know, Kribil did transeptal TAVI case, and we reduced it to 14F. And in return of what did we get that? So in order to have a low profile, actually, we started to cripple the valve more, which means that we have made it thinner, a lower profile, you know, we incorporated into a lower profile system, which meant that the valve in the bench tests is simply, it means that it's subject to a deformation. So a 10-year-old period, if we, for example, had 10-year-old evidence, if you simply cripple it, it means that the rate is going to be even lower. So the third thing is, in this respect, in order to simply offer a solution to this durability problem, these young patients, first, simply doing the surgical procedure, you know, shall we do the TAVI into the surgical valve, or then TAVI in TAVI? Because we don't have any information as much as I know. What are your opinions about all these aspects? Thank you so much, and thank you in advance.
You know, I think that you pointed out very important issues. I mean, the most important result, I think, of the trials, the low-risk trials, is that we can reasonably apply TAVI, I think, to all patients without, I mean, discussing all the things that you said without taking into account the surgical scores of, I mean, we, in the heart team, we can discuss the patient irrespective of the risk, and the patient will have different characteristics favoring one procedure or the other one, which may be also, you know, prefer a surgical procedure in an intermediate risk patients because maybe he has a very important LVOT calcification or lower coronary takeoff. So thinking about the future or you know, so I think this is the most important results. In terms of going to younger patients, I think this is different because at the moment, yes, we have reassuring data, but as you pointed out, we don't know. We know from microstructural evaluation of the leaflets of a valve that there may be some locus minoris resistentia after the crimpage of the valve. We know that there may be some, you know, technical mistakes in which you do not have an excellent results, and you may, you know, with post-dilatation do something to the valve structure. So I think that for younger patients, and when I say younger, I don't know where to put, you know, the threshold, because as you mentioned, we had 25% young patients in the low risk. But I think we simply need to wait a little bit longer follow-up and of course study well what can be the, you know, the issues for the future. I don't know if I addressed your question, but I think all the discussion now is there. And if you take a look at one of my first slides, what is going on, for example, in Bologna, is that basically, I mean, the surgical procedures, biological, now performed in patients between 65 and 75, 80 years maximum. So this is already happening irrespective of surgical risk. And the other phase of the coin, which is very positive, I didn't show that, but surgical mortality in our hospital now is well below 1% because the worst patient we are treating with TAVI.
Well, thank you so much as well. Actually, we have completely beyond our time. And we also see that there are so many enigmas, right? Just like in the other domains. From a technical perspective, there are so many unknown factors that need to be taken into consideration. On the other hand, epidemiological perspective, you know, in terms of doing something for the masses, there are a number of issues. But as years go by, I believe we will make progress, as Vahaya says, in 2020. I'm not sure whether that is going to be default for everyone. I don't think so. At least the financial situation might simply inhibit that, particularly in terms of the youth. We have issues, as Francesco put it very well. If you allow me, I would like to adjourn the session. If Muzaffer would like to say something. I would like to take this opportunity to thank Muzaffer and Dr. Francesco, because at this time of the day, he was kind enough to join us and make a great presentation. And all of our attendees, panelists, my colleagues who are still here in front of the screen, thank you so much. And hopefully we're about to simply initiate a registry, and our cases are going to be accumulated more, and I hope we will have much more evidence about Turkey. Thank you so much and have a great night. Thank you.
Thank you.
Professor Muzaffer. Well, as a last remark, I would like to thank everyone, all of our panelists, all of our attendees, and our distinguished colleagues. My panelists, you did a great job. It was a perfect webinar. We heard so many valuable information. I learned so much. And Francesco, thank you so much. I mean, we kept you until this time. Thank you very much. It was very kind of you. Thank you very much for your contributions. And Faruk, you know, I hope you are feeling much better. He has suffered from COVID-19. And by this opportunity, I would like to simply send my best wishes to my colleagues who have recovered from COVID. And, you know, for the ones who have lost their lives, may God rest their souls in peace. Thank you so much. Have a great evening.